This episode is produced for educational purposes only. It does not constitute legal advice or medical advice. Laws, regulations, and standards of care vary by jurisdiction. Case details are drawn from publicly available sources. Clinical scenarios are presented for educational analysis. They should not be used as the basis for individual treatment decisions. If you need legal guidance, consult an attorney licensed in your jurisdiction. A study published in JAMA Internal Medicine in 2023 examined over 108,000 emergency department visits at 104 VA facilities. Researchers wanted to know a simple question. Does the wording in a triage note change how physicians work up a patient? The answer was unambiguous. When the triage note mentioned congestive heart failure, physicians were 1/3 less likely to order testing for pulmonary embolism. They took 15 additional minutes to order the test when they did. And the rate of actual pulmonary embolism was identical in both groups. The only variable that changed was the label.
That is an interesting observation, and I think it is worth sorting through why that might be the case. 1/3 less likely to test for PE, not because the patients were different, not because the clinical picture was different, but because of how someone described the reason for the visit before the physician walked into the room.
The researchers, Lai, Shikele, and Song, found that physicians ordered more cardiac testing when the triage note mentioned heart failure. BNP testing went up to 78% compared to 71% without the label. The diagnostic frame had shifted toward cardiology before the physician made a single, independent observation.
I had noticed this pattern in practice, an incomplete triage note or an early label seeming to direct the rest of the encounter. And I wanted to find out whether the research supported what I was observing. It does. Every one of us inherits charts with labels already on them multiple times per shift. The triage nurse has documented a chief complaint. The EMS crew has radioed ahead. The prior shift has carried forward an assessment. By the time you see the patient, there is already a working hypothesis in the chart, and you did not generate it.
Today we are going to examine how that mechanism, the anchoring of downstream clinical reasoning by an initial triage label, plays out in malpractice litigation, what the evidence says about why it happens, and what you can do differently on your next shift. We have cases ranging from a $20 million verdict to a $27 million verdict, a landmark study that quantifies the problem, and a gap in professional training that no one is talking about. Peter, 5.
Sarah, before we get into cases, can you walk us through the cognitive mechanism here? What does the research say about how a triage label actually affects the physician's thinking?
The mechanism is called anchoring bias, and it was first described by Tversky and Kahneman in 1974. In clinical medicine, Pat Crosscarry, who's probably the leading voice on cognitive error in emergency medicine, defines it as the tendency to lock onto salient features in the initial presentation too early in the diagnostic process, and then failing to adjust when later information contradicts that initial impression. What makes triage anchoring distinct from other forms of anchoring is that the anchor is set by someone other than the treating physician, and it is set before the clinical encounter begins. The physician reads the triage note, walks into the room, and is already operating within a diagnostic frame they did not choose.
And that is how it works. Crosscarry describes it through dual process theory. System 1, which is fast, intuitive pattern recognition, seizes on the triage label as a plausible hypothesis, and System 2, the slower analytical reasoning that should override it, often does not activate because the label seems reasonable. The label does not need to be wrong. It just needs to be incomplete.
A 2020 study by Drapkin and colleagues examined this in a different clinical context: pediatric appendicitis. They reviewed over 1,600 cases and found that when the triage chief complaint was nonspecific, fever, vomiting, dehydration, The appendicitis miss rate was 8.8%. When the triage complaint was suggestive of appendicitis, abdominal pain, right lower quadrant pain, the miss rate dropped to 3.8%. That is an odds ratio of 2.46. Patients were 2.5 times more likely to have appendicitis missed when the triage label did not point toward it.
And there were no differences in age, sex, white blood cell count, or fever between the groups. The only variable was how the triage nurse described the reason for the visit. The clinical picture was the same, the label was different, and the diagnostic accuracy moved with the label, not the patient.
From a legal standpoint, what that study gives a plaintiff's attorney is a quantifiable mechanism. It is no longer speculative to argue that the triage label narrowed the differential. There is published peer-reviewed data suggesting the effect size, and the defense argument that the physician exercised independent judgment becomes harder to sustain when the data suggests that independent judgment is measurably influenced by the first thing the physician reads.
In August 2013, a 30-year-old woman who had recently given birth after a difficult, prolonged labor presented to the emergency department at a large metropolitan hospital in the upper Midwest. She was 3 days postpartum. She reported chills, nausea, worsening pain, and fever. Her triage vitals documented tachycardia and an elevated temperature. Laboratory work revealed a highly elevated white blood cell count with a left shift and bandemia, and a platelet count of 50,000. Normal range is 150,000 to 450,000. She met the criteria for systemic inflammatory response syndrome.
Those labs paint a clear aggregate picture. White count up with a left shift, bandemia, thrombocytopenia to 50,000 in a young woman 3 days after delivery. SIRS criteria met. The question that data raises is consumptive coagulopathy, possible DIC, and the source should be presumed systemic until proven otherwise.
The emergency nurse practitioner noted white blood cells present in the patient's urinalysis. Despite the absence of localizing urinary symptoms, no frequency, urgency, or dysuria, the practitioner diagnosed a urinary tract infection. She prescribed oral antibiotics and acetaminophen and discharged the patient home.
And that is the anchoring mechanism. A localized finding with white blood cells in the urine provided a cognitive explanation for the systemic picture. I see providers do something similar when there is any bacteria or white cells in the urine. They gravitate toward the easy explanation. This may be an extreme case, but it happens. And I wonder whether the pressure to rapidly reach a disposition to admit or discharge plays a role. I do not know the answer to that, but I think it is a question worth asking. Once you have a plausible localized source, the systemic markers get rationalized as secondary. The elevated white count becomes consistent with infection. The tachycardia becomes consistent with fever. Each piece of the SIRS picture gets folded into the localized diagnosis instead of being recognized as evidence that the infection has already gone systemic.
The defense in this case reportedly acknowledged that the practitioner failed to appreciate the significance of the platelet count and the systemic inflammatory response indicators. The legal dispute centered primarily on damages, not on whether the standard of care was met.
12 hours after discharge, the patient lost consciousness at home. She was rushed back to the same emergency department, where a different team immediately diagnosed severe sepsis originating from postpartum endometritis. She progressed to multiple organ failure and refractory septic shock and died the following day.
This was a young, otherwise healthy patient with clear lab abnormalities and a recent delivery. Findings that should raise suspicion for something more serious than a simple urinary tract infection. UTs rarely produce that degree of leukocytosis with bandemia and thrombocytopenia in a healthy young woman. In hindsight, the systemic picture is difficult to miss, but for the provider in that moment, that is the power of this bias. It can redirect your clinical reasoning without you recognizing it is happening, and that is what makes it worth studying.
A jury returned a verdict of $20 million. At the time, the largest wrongful death medical malpractice verdict in the state's history.
From a litigation perspective, this case illustrates a pattern seen in anchoring cases. The lab results were documented. The SIRS criteria were met. The diagnosis that should have triggered aggressive intervention was replaced by a diagnosis that led to discharge with oral antibiotics. That gap between what the data supported and the clinical decision is the type of evidence that becomes central to the plaintiff's case at trial.
In February 2017, a 48-year-old man presented to an acute care clinic in a Midwestern city with fever of 103.6 degrees, dizziness, fatigue, and cough. His heart rate and respiratory rate were both abnormally elevated. He was severely disoriented, delusional, and combative. A nurse took the initial history from the patient's wife and attempted a flu test before the treating provider, a physician assistant, entered the examination room. The nurse reported the clinical picture to the PA with a framing consistent with influenza during peak flu season.
And that is the first anchor. Before the PA walks into the room, the encounter has already been framed as flu. It is flu season. The nurse has reported symptoms consistent with flu. The flu test has been ordered. The diagnostic direction has been set.
When the PA entered the room, according to trial testimony, her first words were directed at the patient's presentation. She asked whether the patient was withdrawing from something. The patient's wife responded that her husband did not use drugs.
So now we have two anchors layered on top of each other. Influenza from the nurse's intake and substance-related frame from the PA's initial impression. It might be understandable for either of those considerations to enter your mind given the presentation, but the clinical discipline is recognizing when those initial impressions are forming and maintaining a neutral diagnostic posture. Let the objective data, the fever of 103.6, the vitals, the exam, lead you to the diagnosis rather than the initial pattern match.
The flu test came back negative. According to her trial testimony, the PA discounted the result, stating she believed the patient still had the flu because flu tests are not completely reliable. No complete blood count, blood cultures, or additional infection workup was ordered. The patient was diagnosed with influenza and discharged.
The negative test result is a significant detail from a legal standpoint. The flu test was the objective data point that should have prompted reconsideration. Instead, the anchoring was strong enough that the provider rationalized the negative result rather than letting it challenge the working hypothesis. That is a pattern that the plaintiff's counsel highlighted effectively. The provider had an opportunity to reassess and instead found a reason not to.
And that reasoning, flu tests have false negatives, is technically correct. Rapid influenza tests do have limited sensitivity. But that argument cuts both ways. If you are going to acknowledge that the test is unreliable, then you cannot use the clinical suspicion alone to close the differential. A negative test in a patient with 103.6 fever, delirium, tachycardia, and tachypnea should widen the workup, not narrow it.
2 days later, the patient was brought to an emergency department, where bacterial meningitis secondary to infective endocarditis was diagnosed. He was placed in a medically induced coma for 8 days. He suffered 3 strokes. He was ultimately left with permanent brain damage, complete hearing loss in one ear, nerve damage, vertigo, and significantly impaired cognition. He spent months relearning to walk, talk, feed, and bathe himself. Michael first noted the triage anchoring pattern while reviewing this case for a previous episode. The way the initial provider's documentation seemed to direct every subsequent clinical decision. That observation led to the research behind today's episode. The defense had offered $250,000 1 week before trial, The jury returned a verdict of $27 million.
The verdict breakdown is instructive. $12 million for future loss of full mind and body function, $10 million for future pain and suffering, and the remainder for past damages. The magnitude reflects the jury's assessment of the lifetime impact. A 48-year-old who will never return to his prior level of function.
The PA herself testified, "If I could go back, I would have done more." That is a heartbreaking statement. I am sure she is devastated by the outcome for this patient, and you can hear it in those words. None of us go into an encounter intending to miss the diagnosis, and certainly not intending for a patient to suffer this kind of harm. These cases affect us deeply as providers. That human weight is real, and I do not want to minimize it. But I do want to flag something we have talked about in earlier episodes: the importance of being careful with the statements you make under oath. In this case, the evidence was well in support of the plaintiff, and it may be that her comment reflected something genuine. The human component, the devastation that providers carry when an outcome goes wrong. I understand that. But, as a general principle, I remind providers to be thoughtful about testimony. Statements made under oath become part of the legal record, and they can be used in ways you may not anticipate. That is not a criticism of this provider. It is a reminder for all of us.
Not every triage anchoring case involves the triage label leading providers astray. In some cases, the triage documentation captures the critical finding, and the physician fails to act on it. In January 2010, a woman in her 60s presented to a hospital emergency department and was diagnosed with an influenza-like illness and a cervical neck strain attributed to recent physical activity. She was discharged with medications for flu symptoms and muscle pain. Her condition deteriorated rapidly overnight. She returned the following morning. The triage nurse documented her chief complaints as severe vomiting, an extreme headache rated 10 out of 10, and severe neck pain. The nurse explicitly tested for nuchal rigidity, asking the patient to touch her chin to her chest, and the patient was unable to do so. That finding was documented in the triage note.
And that is a triage nurse doing exactly what she should be doing. She recognized a constellation of symptoms: vomiting, severe headache, neck pain, that should raise concern for a central nervous system infection. She performed a focused physical exam maneuver, documented a positive finding, and created a medical record that clearly flagged the concern. That is good triage.
Laboratory results showed a white blood cell count of 19,200 with a severe left shift. An MRI was performed and showed meningeal enhancement. The radiologist formally recommended a lumbar puncture. Despite the triage nurse's physical exam findings, the elevated lab values, and the radiologist's recommendation, the treating emergency physician anchored on the previous day's discharge diagnosis. The record indicates the physician concluded the patient was experiencing a continuation of the flu-like illness, combined with a cervical neck strain or muscle spasm. The patient was discharged again with anti-nausea medication and pain medication. No lumbar puncture was performed.
And this is the version of triage anchoring that works in the opposite direction. The prior encounter's label, flu-like illness, neck strain, became the anchor for the second visit. The triage nurse generated new data that contradicted that anchor. The lab results contradicted it. The radiologist contradicted it, and the anchor held.
This case produced a $3 million jury verdict, and it was upheld on appeal. The appellate record is publicly available, which makes this one of the better-sourced cases we can discuss. The defense presented a complex causation theory involving a pre-existing condition, but the jury found the physician's failure to perform the recommended lumbar puncture constituted a breach of the standard of care.
What I want our audience to take from this case is that triage documentation can work for you or against you. In the first case, we discussed a localized finding anchored the provider away from the correct diagnosis. In this case, the triage nurse captured the correct clinical picture and the physician overrode it. Either way, the first label in the chart shaped the outcome. The question is whether you treat that label as the answer or as a hypothesis that still needs testing.
There is a specific variant of triage anchoring that is particularly dangerous and particularly difficult to protect against legally. When a patient presents with altered mental status and is labeled as intoxicated, the label does not merely narrow the differential. It can effectively remove the patient from the acute disease paradigm entirely.
This is an important legal distinction. With most anchoring patterns, flu-like illness anchoring away from meningitis, back pain anchoring away from epidural abscess, the provider is still operating within a medical framework. They are making a diagnostic judgment, even if it turns out to be wrong. With an intoxication label, the framing shifts from, "What disease does this patient have?" to, "This patient is intoxicated and needs to metabolize." The diagnostic search effectively stops.
In a case decided by the 10th Circuit Court of Appeals, a man was observed at a motel staggering, running into objects, and severely slurring his speech. Responding paramedics and police noted the smell of alcohol in a partially consumed beer container. He was arrested for public intoxication. At a detention facility, 2 nurses evaluated the patient. He explicitly denied drinking alcohol. A brief neurological examination showed equal pupils and bilateral grip strength. Over the next 6 hours, he was repeatedly evaluated as his condition deteriorated. Complaints of severe dizziness, ringing in the ears, rising blood pressure, confusion, and continued slurred speech. Every deteriorating sign was attributed to the initial anchor of alcohol intoxication.
And that is the clinical reality that makes the intoxication label so dangerous. Acute alcohol intoxication causes disinhibition, incoordination, slurred speech, and an unsteady gait. A cerebellar stroke causes a similar presentation in some circumstances. They can be clinically indistinguishable by observation alone, particularly in the early hours. And the research suggests that between 26 and 52% of stroke presentations transported by EMS are not recognized as strokes by paramedics, with the highest miss rates in posterior circulation strokes, which are exactly the ones that can mimic intoxication.
The patient collapsed approximately 6 hours after his initial evaluation. He was transported to a hospital and diagnosed with a massive cerebellar stroke, resulting in permanent neurological deficits.
What makes this case legally significant is that the appellate court affirmed a defense verdict. The court drew a distinction between a negligent misdiagnosis and deliberate indifference, which was the constitutional standard required in that custodial setting. The court found that because the symptoms of cerebellar stroke so closely mimic intoxication, the nurse's failure to diagnose did not rise to the level of conscious disregard.
It is worth noting that this case was decided under a different legal standard. Because the patient was in custody, this was a federal civil rights claim. The standard was deliberate indifference, which requires the provider to actually know of and consciously disregard a serious risk. That is a much higher bar than the negligence standard that applies in the emergency departments and clinics where most of us practice. In a standard malpractice setting, this same cognitive error would likely be evaluated differently. The clinical teaching point remains the same regardless of the legal setting. Intoxication is not usually an emergency unless it involves multiple substances or overdose. It does not require time-sensitive intervention in most cases other than fluids and time. But many of the conditions that mimic intoxication or stroke, intracranial hemorrhage, hypoglycemia, meningitis, are emergencies. The discipline has to be, do not let the intoxication label stop you from examining the patient and giving them the time necessary to rule out real pathology. A patient who is sleeping off intoxication and a patient who is declining from a posterior circulation stroke may look identical for hours. Serial neurological exams and a low threshold for imaging are the difference.
Sarah, we have talked about the initial anchoring event. But the research suggests the problem does not end with the first provider. Can you walk us through how the label propagates?
The propagation pathway operates through 5 reinforcing mechanisms. First, a label is assigned at triage, typically by a nurse operating under significant time pressure, distilling a complex presentation into a chief complaint category. Second, the treating physician reads that label before seeing the patient. The EHR displays it prominently. The anchor is set before the clinical encounter begins. Third, once anchored, the physician interprets subsequent findings through the established frame. That is confirmation bias, activating on top of anchoring bias. Fourth, if the patient is seen by multiple providers, a shift change, an admission, a consultation, each subsequent provider inherits not just the triage label, but the accumulated diagnostic momentum of every provider who accepted it before them. And fifth, this is where the EHR becomes a structural amplifier. Copy and paste functionality and problem list propagation embed the initial label throughout the record. A 2017 systematic review by Tsu and colleagues found that between 66 and 90% of clinicians routinely use copy and paste. A study at UCSF found that only 18% of text in a typical patient record was original. 46% had been copied and pasted, and 36% had been imported from other sources. When an initial triage label enters that ecosystem, it is overwhelmingly likely to be propagated verbatim rather than reassessed.
And that is something I think about as a hospitalist. By the time I see a patient on the floor, the chart has already been written by the ED provider, maybe a consulting service, maybe an overnight admitter. I am reading layers of documentation, and the original triage label is embedded somewhere in all of it, often in the chief complaint field that carries forward to every note. If we do not independently reassess the patient, we are building our clinical judgment on a foundation that someone else laid at triage.
One of the most striking findings in the research for this episode is what is absent from professional training and guidelines across all disciplines, not just nursing.
We reviewed the Emergency Nurses Association position statements, the ESI Implementation Handbook, the ACEPENA Joint Policy Statement on Standardized Triage, and the Canadian Triage and Acuity Scale Guidelines. All 9 published clinical practice guidelines, which were appraised in a 2026 systematic review and all rated low quality. None of these documents address the downstream anchoring risk that triage documentation creates for physicians. But it is also worth noting that physician training programs do not systematically teach providers how to recognize and override triage framing either. This is a system-wide gap, not a failure in any one discipline's education.
The ENA's Emergency Nursing Triage Education Program, the standard structured training requiring 1.5 days of instruction, covers ESI application, chief complaint assessment, and acuity assignment. Based on publicly available curriculum descriptions, the program contains no module on how triage labels affect physician reasoning. And medical residency curricula similarly do not address how to process inherited diagnostic frames.
This is a system issue that requires a system-level response. The first step is education and awareness. Understanding that this bias exists and that there is research data quantifying its effect. The research demonstrating the anchoring mechanism of triage labels is relatively recent. Lai and colleagues published in 2023, Drapkin and colleagues in 2020. The evidence base is still building. Once we understand the mechanism, we can build structural solutions. But the starting point is recognizing that this is happening. And it is happening to all of us.
From a legal perspective, that training gap creates what could be characterized as an unopposed liability vector. If no professional guideline acknowledges the risk, no training program addresses it, and no institutional policy accounts for it, then neither the individual provider nor the system has a structural defense when the anchoring mechanism leads to harm. The AHRQ Patient Safety Network has published case studies addressing this exact dynamic. Their commentary on one case states plainly that triage is not designed to be part of the diagnostic process, but the cognitive and social reality is that triage often plays a de facto role in it.
That is exactly the gap we are identifying. Triage documentation is designed for resource allocation and acuity assignment. It should not be functioning as the first entry in our differential diagnosis. But the cognitive reality, as the data suggests, is that it does. And that disconnect between what triage is designed to do and what it actually does to our reasoning is what we need to address.
Michael, we have established the mechanism, the legal consequences, and the training gap. What does the evidence say about what actually works to counteract triage anchoring?
The honest answer is that the evidence is more limited than I would like it to be. Most individual debiasing strategies, teaching about cognitive bias, checklists, structured pauses, have shown mixed results in the studies that have tested them, but there is one trial that stands out.
The CHARMED trial, published in JAMA Internal Medicine in 2018, was a cluster randomized crossover trial conducted across 6 French emergency departments with over 1,600 patients. The intervention was systematic cross-checking between emergency physicians 3 times daily. One physician briefly presents a case to another, who provides feedback without relying on the primary physician's notes.
And the results were significant. Adverse events dropped from 10.7% to 6.4%, and that is a 40% relative risk reduction. Near misses showed a 47% relative reduction. The number needed to treat was 24, meaning for every 24 patients treated under the cross-checking protocol, 1 adverse event was prevented. What I find compelling about CHARMED is that it is not asking individual physicians to override their own cognitive biases through willpower. It is building a structural check into the workflow. A second physician who has not read the triage note, who has not been primed by the chief complaint label, looks at the case with fresh eyes. That fresh perspective is what breaks the anchoring chain. I recognize the practical challenge. Rural emergency departments and facilities already running over capacity may not have the staffing to implement structured cross-checking 3 times daily. The principle is sound. The implementation needs to fit the environment. But this type of process, a built-in mechanism for a second set of eyes, may be the framework that actually works.
There is also pilot data on diagnostic timeouts, structured pauses modeled on the surgical timeout, where the team asks, what else could this be? A study by Yale and colleagues found that in more than half the cases where a timeout was performed, it did not confirm the initial diagnosis, leading to pursuit of alternatives. However, a larger study by Gupta and colleagues found that no component of their diagnostic bundle was utilized by more than 50% of providers, suggesting that even well-designed interventions fail when they create workflow friction.
And that is the practical reality. We work in environments where time pressure, cognitive load, and patient volume make it difficult to add steps to the workflow. The interventions that work are the ones that fit into existing patterns. Like the CHARMED cross-checking, which is essentially a structured version of something physicians already do informally when they curbside a colleague. The interventions that fail are the ones that ask you to stop, pull out a checklist, and work through a protocol in the middle of a busy shift.
Sarah, there is a notable absence in the research we reviewed. Can you describe the single largest intervention gap?
No study has tested switching triage documentation from diagnosis-inclusive to symptom-only format. That is the most direct intervention the evidence implies. If the chief complaint label creates the anchor, then removing diagnostic language from the label should reduce the anchoring effect. Instead of logging CHF exacerbation, the triage nurse would document shortness of breath with peripheral edema. Instead of migraine, the documentation would read severe headache with photophobia, sudden onset.
And the reason that matters is that it preserves everything the triage nurse needs for acuity assignment. The symptoms drive the ESI level, while removing the diagnostic frame that narrows the physician's thinking. The same principle applies to subjective labels, terms like intoxicated, frequent flyer, or drug-seeking. Those labels may reflect an observation, but they do not belong in the chief complaint or the clinical framing of the encounter. If that information is relevant, it could go in the social history or another section of the record, somewhere that informs without anchoring. The chief complaint should describe what the patient is experiencing, not what someone has concluded about them. One study evaluating an automated symptom-based ophthalmic triage tool found 97% agreement with final physician assessments and 0 instances of dangerous under-triage. The approach works in at least one clinical context, but no emergency department has formally tested it, at least not in any published study we could identify, and measured the effect on diagnostic accuracy.
From a systems perspective, this is the kind of intervention that would require collaboration between nursing leadership, EHR vendors, and medical staff governance. It is not something an individual physician can implement, but it is also the kind of intervention that, if validated, could potentially help address this problem.
Michael, bring this home for us. What can a physician listening to this episode do differently starting on their next shift?
3 things, and I want to be realistic about what is within your individual control and what requires system-level change. First, and this is the recommendation with the strongest evidence behind it, form your own clinical impression before you read the triage note. I know that sounds impractical. Most of us read the triage note on the way to the room, but even a brief independent assessment, walking in, looking at the patient, taking vitals yourself, asking them in your own words what brought them in, gives your brain an independent data set before the triage frame takes hold. You are not ignoring the triage note. You are sequencing your information intake so that your initial impression is yours, not someone else's. Second, reconcile the triage note in your documentation. If the triage note says neck pain and you found upper back pain, document why the discrepancy exists. If the triage note documents findings you did not observe, like the meningitis case we discussed where the nurse documented neutral rigidity and the physician charted a normal exam, your chart needs to explain that gap. Silence on the discrepancy is what creates additional liability. Third, treat return visits as cognitive forcing events. A patient who comes back with the same complaint is a natural signal that the first diagnostic frame may have been wrong. The working diagnosis was tested by time and found insufficient. That is your debiasing opportunity. Do not re-anchor on the previous visit's diagnosis, reassess independently. In multiple cases we discussed today, the return visit was where the anchor should have broken and did not. And one more at the system level. If you are in a leadership position, medical director, department chair, program director, consider looking at the CHARMED trial data. A structured peer cross-checking protocol 3 times daily reduced adverse events by 40%. That is a formalized version of something we already do informally. It does not require new technology or a new triage system. It requires protected time for physicians to present cases to each other. That is an achievable intervention with the strongest evidence base of anything we discussed today. Whatever we implement, we need practitioner buy-in. And to get that, we need to be honest about the environment. Physicians and nurse practitioners are already working at or above capacity. Adding burdensome protocols without explaining the evidence behind them is not going to work. The data might help make the case, but the intervention itself needs to respect the reality that the people we are trying to help are already stretched thin.
The first label in a patient's chart sets a diagnostic trajectory that is measurably difficult to override. Whether that label is set by a triage nurse, an EMS crew, or a prior encounter, the evidence shows it changes how physicians generate differentials, order tests, and interpret results. The legal system has quantified the cost, verdicts in the millions for patterns that are reproduced across every acute care setting in the country. And the most direct intervention, restructuring triage documentation to separate symptoms from diagnoses has never been formally tested.
The bottom line is this. The chart already has an opinion before you do. Your job is to form your own.
Thank you for listening. If you found this episode valuable, a paid subscription to the Charted Defense supports ongoing research into how clinical decisions become legal evidence and gives you access to our full archive of deep dives into the cases and patterns that define medical malpractice risk. I am Bryan. Alongside Sarah and Michael, this has been The Charted Defense. This episode is produced for educational purposes only. It does not constitute legal advice or medical advice. Laws, regulations, and standards of care vary by jurisdiction. Case details are drawn from publicly available sources. Clinical scenarios are presented for educational analysis. They should not be used as the basis for individual treatment decisions. If you need legal guidance, consult an attorney licensed in your jurisdiction.